class 3 malocclusion because it is a challenging malocclusion. So I will cover with you the 3 phases of class 3 treatment. So again, what's the right timing for the first consultation? The age of 9. But in the class 3 cases, are we going to do the same in terms of timing of treatment? In class 2, it depends on the overjet. So how to have a smile orthodontics in the class 3 cases? Always, we consider this malocclusion as a challenging malocclusion. So as we have said now, timing. When should we start the class 3 treatment? This is the first challenge. The second challenge is patient selection or case selection. Number 3, the unwanted forces of class 3 mechanics. And most of your class 3 cases, the maxilla is constricted again. Even it is more constricted than the class 2 cases. So how to deal with these challenges? We start with the timing. Should we treat any class 3 case? In the class 2, we took the 6 millimeter overjet as our reference. What about the class 3? Are you going to treat any class 3 case? Depending on what reference? Why you are going to decide, I'm going to do the treatment now for one case, or I want to delay the treatment on the other case? What will be your reference? What do you think? If you have a case of a class 3 and the age is 9, and another case 12, the third case 16, which one you are going to start with? I need your help. It depends on you have positive overbite or not. So if you have a class 3 with overbite tendency, are you going to treat that case? Class 3 with overbite. Are you going to treat that case once you have it in the practice? Or maybe it's better to delay the treatment? So in such cases, no. I will not bond the case. I will wait. And I will establish good habits. Lip seal, nasal breathing. On the other hand, if I have a class 3 with anterior positive overbite, which means I have a crossbite. So this should be treated once diagnosed because we have crossbite. But while you are discussing that with your patients, you need to remind them that they will need 3 phases of treatment. You will do phase 1 at the age of 9. Then we need to evaluate the case at the age of 12, 13 to see the need for phase 2. And in some cases, you need even to evaluate the case after the age of 16 to see the need of phase 3 because it's related to growth. It's not under your control. Remember, 3 challenges. Time, growth, unwanted forces, okay? So this is my protocol. Again, what's missing in our profession is management. So we need to manage when to see our patients as consultation and when to start the treatment. So this will help you to have the right start with your patients. So this is for the timing. Now we know when to start the treatment. For the case selection, I would prefer to start with normal growth and the upper anterior teeth, they are not compliant, the lower anterior teeth, they are not compliant, we don't have good conversation, and the patient can bring edge-to-edge bite. And we need to examine the patient in centric occlusion and centric relation. For example, if this is your case, is this orthodontic or surgical case? If we have a surgeon now between us, and this is his case, and the age is 24, what's the treatment plan by the surgeon? Concave profile, he will evaluate it as still a class 3 adult patient. This patient will need orthodontic surgery. This is the opinion of surgeons. But again, this is centric occlusion. So ask your patient to bite in centric relation. Are you going to do surgery for that profile? Of course not. So if you evaluate the profile in a centric occlusion, maybe you'll go for surgery. This is wrong. You need to evaluate the profile in centric relation. So the profile is normal. So this is a recommended case for it. So let's start with phase 1 treatment. Younger children, once diagnosed, if you have positive over 5. This is Judy. She's 9 years old and she has anterior cross bite. She has concave profile and she has positive over bite. These are the intraoral photos for Judy. If this is your case, what's your plan? Are you going to put brackets? I will tell Judy, look Judy, your dad will pay 1,000 USA dollars for your treatment. So why not to help your dad to save some money? Why not use that tongue depressor 2 hours per day for 2 months? By this you will save 1,000 USA dollars. This is in front of the parents. So the parents will be more than happy to save money. So they will stay consistent or instructing Judy, what's the tongue depressor? What's the tongue depressor? Okay, we want to save money. Okay? And later on, after 3 months, we fix the problem. So if it is initial class 3, you can jump the by tongue depressors. And this is the same case after 3 years. So it was only tongue depressor and no money was spent on the case. So make it simple. So this is in 3 months, 2 months, and this is after 3 years. So it was a stable result. And it was reflected on the face. So she's doing well. That's why I'm moving her case till the age of 16. So this is within 2 months, and this is her profile at the age of 13, after 3 years. On the other hand, in Salma case, we are doing routine consultation as usual. So this is her panoramic X-ray. If you go back, do you see any class 3 occlusion? It's not related to the topic, but you see that later on, intraorally. But to start with the panoramic X-ray, this is your patient. Do you see anything abnormal? What's the red flag in that X-ray? too many things. Number one, she has conjecture missing 5. And what about this canine? Compared to the right canine. So what you are going to do? Her age is 9. What's the most important decision to do by you as orthodontist or pediatric dentist? You have a case like this. 9 years, intensity of action of upper canine. What to do? Preventive extraction of upper C's. It's a must. Once you extract the upper C's, the percentage of self-correction of the upper canines may exceed 78%. So the right timing of early extraction of retained C's, see what will happen? We did that. You see the amount of self-correction. So you need to interfere in such cases to guide the teeth eruption. And I'm doing follow-up for hair bite, so this is hair bite. And that canine was erupted. She has a cross bite. I gave her tongue depressor. She didn't put that tongue depressor. So I told the parents we needed to put braces on her. So the mother told me, give her the last chance. So I needed to add deep grammars on lower left lateral and canine. So she will bite on them like this. So it's minor cross bite, so no need for braces. Still, she is under follow-up. On the other hand, if you have a case like this, Yara, she's 9 years old, she's living in Dubai or Abu Dhabi, and they proposed face mask. Do you think children, they like face mask? By the way, what's the aim of face mask? Why do we need face mask? Why you need face mask? The face mask has no wireless, let's say, connection to the arch, has no magnetics, has no magic. It has only one function, to hold the elastics. So it's about elastics at the end. So if I can apply elastics using braces, why do we use that big, sorry to say, ugly device for our children? So they traveled all the way from Abu Dhabi to Jordan just to avoid face masks. And she has concurred profile. She's showing the lower incisors, not the upper incisors. And these are the intraoral photos for Yara. She's 9 years old. And the upper arch is not constructed. That's why no need for any expanders. And we decided to help her. So we bonded her case. At that time, it was Lemni-Q. So I flipped the retrocline toe. So now it's procline toe because it's flipped. I added deep grammars on the lower two centrals. I'm creating space for the canines. I'm applying buccal classic elastics. It's better to use Belleton classic elastics. And this is the day of bonding. And this is her case after 2 months. She traveled back to Abu Dhabi, then she came back. So we bonded the laterals. We are now in the Cersei wires. And I finished her case in 1 year. So now she is 10 years old. Then I saw her after 1 year. Now she is almost 11 years old. Then I saw her after 4 years. Now she is 15 years old. So it was stability, just by braces. So the job of the face mask is this, elastic. So if I can use the procline torque of lower incisors as my face mask, why use that extraoral device? So a deep grammar we shifted the bite. So from day one, she will leave the practice with edge-to-edge bite. So she entered the practice with concave profile. She left the practice with a straight profile. And within 2 months, we can jump the bite. Now we are in the sessy wear, and like in class 2 cases, your braces, they can do space maintaining or regaining. And we finished her case within 1 year. The same patient at the age of 11, at the age of 15. So the case is stable. So that shift in hair bite in one visit. Hair follow-up visit after 2 months, sassy wires, debonding at the age of 11, at the age of 15. And if you check her lateral staff, it was true skeletal change. Very comparable to the face mask that has only one job, to hold the elastic. We use elastic. So this is her case within 1 year of treatment, and this is her profile after almost 4 years at the age of 15. So even her facial features, they are improving. She's growing, she's happy, and you need to do even phase 2. And now she is showing the upper incisors, not the lower incisors. So it was good improvement. By the way, do you remember the effect of Procline torque on upper incisors in class 2? It was proclination and intrusion. It's the same for class 3. So it will do what, because she is showing lower incisors, and now she is showing upper incisors. So the Procline torque lower incisors will do this. So again, it will do proclination and intrusion. So it will hide the lower incisors. So her case was treated using Demon Q at that time. What about Demon Ultima? Let's take Nahla. Again, she has concave profile, she is 11 years old. Her parotid teeth, they are erupted, but I don't want to make the full comprehensive treatment. I just want to bypass the crossbite at that age. So I bonded her case using Demon Ultima. That's why you know the difference now. With Demon QQ2, you need to flip the brackets on the lower incisors. Torque, if you flip it, it will be Procline torque. With Demon Ultima, you don't need to procline you don't need to flip any bracket. And by the way, the power of Procline torque of Demon Ultima not comparable to Demon Q2 or Q2. More powerful, and it's the best in the market. So this is the bonding session. We bonded her case using retrocline torque on the uppers. Even the center was neutral, and procline torque on the lowers. And the rubber bands, they were volatile. And within one follow-up visit, we shifted her bite, and within 10 months, I finished her case without the need of expanders or face masks. Just early bilateral cluster elastics and anterior deprograms. Space maintaining and regaining. You can do overcorrection. This is the shape of my anterior deprograms on lower 2 centrals. I'll try my best to push her case till the age of 16 to do the final phase 3 treatment. So you will shift her bite from a negative overjet to almost edge-to-edge bite from day 1. And that effect will be reflected on her profile. without the need of any extraoral device or heavy forces. Big change in hair profile. If you want to have active retention and you want to establish nasal breathing, you can use the same theory of Rolf Frankel, functional appliances. So you can use my brace P3 in order to have the flanges pushing the upper lip while you are holding positive over jet. So you can ask your patient to use that device as a retainer at the same time. This will improve oxygenation and this will give you good effect on the muscles of the face. It is like Frankel 3, by the way. So this is for phase 1. So you can help your patients. And by the way, this is very good marketing tool for you, that you are not using face mask. Like Yara, they traveled all the way from Abu Dhabi just to avoid face mask. And we have a lot of children there, they hate face masks. There is a problem with their confidence in life because of the face mask, even indoors. What about phase 2? Like a class 2. In phase 2, it's different story because you need to know what type of class that you have. So, in some cases, you have pseudoclass. So it's not the cross-line, it's collapsed upper arch. The upper arch is constructed because of missing teeth, impacted teeth, buccal displaced canines. In very, very rare cases, you will have a true class 3, in which you have bilateral class 3. These are very rare cases, but most of your cases, they are class 3 subdivision. So the patient has a class 3 more on one on one side, and the other side is a class 1. So in these cases, I mean class 3 subdivision, you need to apply asymmetrical mechanics. I mean the force of your class 3 mechanics should be more on one side than the other one. Let's have a pseudo class 3 case. This is Dina, and you are good orthodontist. So you need to think about everything. Her age is 15. So she is not phase 2, and she is not phase 3. Should I wait till the age of 16? We need to check everything. So she has constructed upper arch. He has increased lower pressure third. We have a problem of vertical growth. If you go to the case selection, she is not the right case because she has increased lower pressure third. She has high angle case, and this will increase, and still she has growth. But if you check the intraoral photos, he has constructed upper arch, and the most important thing in her case is lower sixes. Lower sixes, they are badly distracted, bad filling, and we are not sure about their prognosis, even if you check their height. No crown. And she has a pseudoclass 3 because of buccal displaced upper canines. So the maxilla is collapsed. That's why the maxilla couldn't include the lower arch. If you check the panoramic X-ray, both lower sixes, they have infiltrated with big fillings. Do you consider this a good tooth with good prognosis? Or poor prognosis? It's a poor prognosis. So even if you put the best filling, just the crown, you will lose that tooth sooner or later. At the same time, we have the aids. We have wisdom teeth. So what do you think should be the plan? So orthodontics is about management for your cases, then good planning. What's the plan of such case? And it should be strategic plan. You are good planner. So what do you think we should do in such case? Should we delay the treatment or to do the treatment? This is the first question. Do it or delay it? Do it. Number one. Number two, are we going to bond both arches or one arch? One arch, the upper arch. Yeah. What to do for lower sixes? Extraction. Without any bonding for the lower arch. The teeth will have mesial drift, because she is high angle case, and the mesial drift will be faster in her case. And if we check the lateral staff, we need to check her profile in centric relation. So this is her profile in centric relation, and this is her profile in centric occlusion. So almost case selection is there. So we bonded her case, only the upper arch, using the right torque. We are creating space for the canines. We are not using any class 3 mechanics because she is in a pseudo class 3. We included the upper right canine. Then I bonded the upper left lateral and included the upper left canine. Still we are in the first wire, by the way, which is 14. And all of that was enough to correct the cross line. So this is the right focal view. Deep-grammars, they were on lower 7s. I will not extract at the start because I was not sure that they would complete the treatment. So I want to bond the brackets first to make sure that she is a cooperative patient. Then I can do the extraction. So we did the extraction of lower 6s. You will have mesial drift of 7s. And the wisdom teeth, they will erupt at the site of lower 7s. We don't have now crossbite. All of that is in 2 follow-up visits. So you can see with me the amount of arch development in 2 follow-up visits. Still, we didn't insert the ultima wires. And for the lower arch, these are the lead grammars. And before extraction, I removed them. And I sent her to extract lower 6. So this is her X-ray after extraction. With time, we'll have mesial drift of 7s, then 8s. For the upper arch, I will not finish an ideal occlusion. I just want to bypass the crossbite and to give her a smile, acceptance smile. Then I'll do debonding. So it will be very fast treatment, maybe 6 months. Then I will leave her by till the age of 18. Once we have the 8s erupted, then I'll do the final phase 3 treatment. So it will be express, very fast treatment in terms of phase 2. Then we'll do phase 3 later on at the age of 18. And for the upper jet, without any class 3 mechanics, because the etiology behind her class 3 is collapsed upper arch. So in pseudo class 3, the maxilla is constricted because missing teeth, impacted teeth, buccal space canines. You need to do only arch development or space creation, and all of that will help you to bypass the crossbite. I'll do my best to push most of my cases, if they don't have crossbite till the age of 16, to do final phase 3. If they have crossbite, I'll do phase 1. Maybe you can do phase 1 only, then we'll do phase 3 later on for these cases. The most important thing with phase 3 treatment is the following. Is this number. 57. Is there any correlation between class 3 and 57? In 2 days, we extracted 57 wisdom teeth. In 2 days. In these 2 days, the whole practice will be shifted from orthodontic and dentistry toward surgery. And I have a friend, his name is Muhammad. He was dentist. Then he went back to the medical school. So he had dental degree and medical degree. He's so smart and skillful. He's doubly qualified. Then he did the general surgery and maxillofacial surgery. And now he is consultant in UK, in Leeds. So I used to book the flights and the hotel accommodation for Muhammad to come to my practice just for 2 days to do all extractions. And this is the team for the 2 days. I'm the referring doctor. And we have 2 doctors, and these are the assistants. So we used to accommodate 25, 30 patients in 2 days. All of the patients, they are leaving the practice smiling. No swelling, no symptoms, simple, easy extraction. Because the surgeon, of course, this is the surgeon. So, by the way, then, do you know Ali? This is Ali, yeah. This is Rasha, my practice manager. And this is Dr. Dalia, treatment coordinator, Lena, treatment coordinator, Ghanem, cosmetic dentist, Rahmi Al-Iman, orthodontic therapist, and the other team. So we used to do extraction of wisdom teeth in 2 days. So this is the most important thing to do for your class 3 cases in phase 3. You need to extract wisdom teeth. So in order to have that correction on your patients, extract wisdom teeth. Of course, we'll extract all wisdom teeth, but mainly lower wisdom teeth. That's why if you delay the treatment to the age of 16, you can take that decision. Then I'm going to apply palatine class 3 elastics with anterior deep grammar and lower 2 centers. I will ask my patient to keep using these rubber bands at 24 hours. This will give you 3 effects. Number 1, this will do arch development for the maxilla. Number 2, you remember the bunting effect? This will give you, I call it face mask effect. So you push the whole maxilla in forward position to support the midface. And number 3, remember, we have a fresh extraction style. Lower wisdom teeth. So imagine if you do the extraction in the middle of the teeth. So you have fresh bone. So the distalization effect will be amazing. And we have procline torque on lower canines. So the roots of lower canines, they are not touching cortical plate. There is no anchoring now. So you do distalization for the whole vertical segment. But remember, in most of your class 3 cases, the midline is shifted. That's why you need asymmetrical mechanics. And the retraction, if you see that, for my lower and 2 segment, it will be asymmetrical. You need it more to one of the sides of the treatment. So in the class 3, phase 3, you need to extract the teeth and you need palatine class 3 elastics. Let's go back for, now we have the right timing, we have the right patient, and we did the extraction, and we have the mechanics. And you know how to do the tool. So let's go back to discuss more about your phase 3. The third challenge is the unwanted forces of class 3 mechanics. And you know now what are the unwanted forces if you apply class 3 elastics. what will happen for the lower incisors? They will come in with extrusion. How to prevent that? Procline code with tabs. Number two, only you have procline upper incisors. How to reduce that? With procline code. This will support the midface. And number three, while you are applying plastic elastics, this is what will happen for the occlusal pain. You will have anticlockwise rotation or upward rotation of your occlusal pain. So the incisor show will be less while smiling. Let's see these unwanted forces in one of my cases. This is one of my old class 3 treatments. Muhammad, he has through skeletal class 3. He couldn't bring edge to edge by. He has deviated change to the left. And you can see his frontal view. You see this, the canopy. And the chin is deviated to the left. And he has complete spine and the lower midline shifted to the left. I treated his case without surgery, without extraction, with the right tone, but I missed some of the unwanted forces. So if you check intraoral occlusion, he's good, except the extrusion of lower incisors, because I didn't add tabs at that time. And if you check his lateral sap, there's a good amount of skeletal change. We shifted his case from surgical case to a non-surgical case. And if you follow the movie on the right side, right screen, I need from all of you to follow the change on the upper lip and the mid face in the case. Follow the movie. It was a big change in his profile. He used to call the practice, told the that I had a cheekbone. So he was the first one who giving me the idea of supporting the mid face. So his feedback about the cheekbone, so everything is great. Even the frontal view, you remember the deviation of his chin to the left? Without surgery, without doing anything, just correcting the class 3, almost we restored symmetrical face. So everything was great. But let's go to his smiling photograph. So in terms of body, lateral sap, profile, everything was great. But for the incisor show, this is what was happening for the incisor show. You see the difference now. Are we increasing or decreasing the incisor show? So the incisor show is decreased because we have anticlockwise rotation of the occlusal vein. So while you are applying plastic elastics, this is what will happen with your patient. Maybe you are happy with the body, with the occlusion, but you will not like the smile. So my mission today is how to treat challenging malocclusion while you are improving the incisor show. So I want you to do the two opposite things together. To do that, you need to have 4 tools. These are the 4 tools that I'm using in order to control everything in class 3 cases. Number 1, you know it now. Parallel talks, you know how to do the talk for class 3. Number 2, you need to modify your practice. So where you are going to put your practice in the center, you can 5.5 or 6? Which one? 6. I want to put them more rigid. Thank you so much. And number 3, I need to modify my class 3 elastics. to make them maybe with different pattern. And number 4, you read tabs. Distant to lower canines. And we'll have a case about each one of these tools. So for variable torques, all of you, you remember the torque selection for a class C. This is your class C torque selection. So you remember from yesterday, Adil, 50 years old, she was convinced that don't do anything, your case is surgical. So she spent her life convinced that no way to treat her occlusion or a smile without surgery. And then at the age of 50 years old, her dermatologist told her, why not you take a second opinion with better? So when she visited me, and I told her that no, I can treat your case without surgery, she was not happy. She was about to cry. Because she felt that she lost the most important years of her life with that smile and that occlusion. And she has to travel from Jeddah, Saudi Arabia, to Amman every 2 months. And she has thyroid problem. She has to take thyroxine, so we don't have right oral modeling. A lot of challenges, and you don't see her smile. She has constricted upper arch, reduced nasal shock from the beginning, and she has facial asymmetry. Which part of the face now is bigger? Now you are expert. Do the face perimeter and tell me which part is bigger now, the right or the left? One of you said the right. Who said left? Yes, it's the right. But as I said, it's not easy to know that from the beginning. But in the primary, you will see the asymmetry. You see the intraoral forces. But before that, the upper incisors, they are proclined. The lower incisors, they are retroclined. These are the intraoral forces for Abi. The upper arch is constricted. All bad crowns. And we have retained C, retained primary canine between the parent canine and toe. So this is the day of bonding. I put the bracket at 6 millimeters. I'm planning to extract that to 10 days of bonding. This is the photograph for the torque. So please take a photograph for your torque selection, your cases, before inserting the wire. That cheek retractor is the cheek retractor for bonding. Don't remove the cheek retractor before taking photograph for the torque selection for all of your cases. Are you happy with the torque selection? Yes. So this is the day of bonding, and we are applying now bilateral plastic elastics. And in the same session, I did extraction for the lower right C, the primary canine. So lower incisors, they are retroclined. We did extraction, and she is applying plastic elastics. If you are not using them ultima, what will happen for lower incisors? They will go to sleep. But let's follow what's happening with her. So this is the day of bonding. She left the country to Jeddah, and we are doing the follow-up. Still we are in the flexible wires. And after our 4th wire, we'll do detailed session, Panorebo. So this is Abi with the Panorebo. So which part of her face is bigger now? The right side. So you will see the canting in the detailed session. So you need to tell your patient that you have face asymmetry. You don't notice that. Once we align your teeth, you will see that. It's not because of our bracket is still in, but we will, let's say, uncover it, we'll remove any camouflage. In that section, I did the position for the upper right, lateral, subcentral, and lower two centers. Now it's time to add tags and a new pattern of elastics. And I'm doing, by the way, if this is your case, how to correct the canting of hairline? How to correct the canting of class 3 smile? In class 2, what we have done? We added one tag to do induction. Are we going to do the same in class 3? No. Because already the maxilla is deficient in class 3. So if you do induction, this is wrong. I need to do extrusion on the left side. That's why in orally, I'm going to apply more intrusion on the lower arch, then more force of the elastics on the left side. Because I like the canted side, and I want to extrude the left side to correct the canting. I finished hair case in 18 months. But remember, I spent the whole time doing class 3 elastics. Lower incisor, they were retroclining, and we had extraction. What do you think now about lower incisors? You see them from the occlusal view and the X-ray. We maintain their position. And no bracket in the market can help you to do that, except their muscle. So again, this is the right occlusal view, this is the size of the extraction. Elephant class 3 elastics, you are not having procline toe, the lower arch will collapse because of the extraction and the class 3. The same on the left side. This is the upper arch. What's the most important tooth in the upper arch? What's the most important tooth in the upper arch? 7. You need to point 7. They are the best reference or cornerstone for you to have the right arch form. These are the buttons for bilateral plastic elastics. You know, you can see with me the amount of arch development. I don't like the old crown, but she needed to change them after finishing the treatment. And retroclining the upper incisors to have one-thing effect to push the maxilla forward. That's why you see the faces of the IVR. So retrocline toe with the upper incisors with IVR will do that function. I was not happy about the finished rotation of the molars, but again she is traveling and she wants to remove the braces. That's why I use finishing aligners. You see them now. But this is the amount of the arch form development in her case. All of that because of the kicking effect of the dental ultima and the power of the bilateral plastic elastic. Now there is any expanded. So your upper 7 are the cornerstone for the arch. And I did some buccal push for the upper 6s and some rotation for the 50 as finishing alignment. For the lower arch, remember, I can see the radial surface of hair lower incisors. This means what? The lower incisors are retroclined. After that extraction, after that cross elastics. First we have anti-tangle thrust, so I added containers. We are closing the space for the old extraction. We are doing asymmetric extraction to the right. And we finish hair case. Compare the lower incisors before and after. Even after, I like them all. Even we have the extraction and the metatarsal elastic. So we have controlled space closure. Again, I did some toy in the molars region. I did some finishing for the lower incisors using finishing aligners. And remember, the upper incisors, they were proclined. Now they are normal, or even maybe they are retroclined. Lower incisors, they were retroclined. Now they are with better inclination, even with the extraction. So this is a good example about the wall of the top of the mountain. And this is ideal before and after. Before and after. And you can see the change on the X-ray. So we supported the whole maxilla, and we put the whole maxilla in more forward position. Remember, 50 years old, traveling, she has thyroid problem. We supported her rib case, and we avoided surgery. All the doctors told her that your case needs surgery. And for the spine, you remember, we have canting. So in the classic cases, I'm not going to do intrusion. I'm going to do stooking using my lower tag. So this is her spine. If you do that. So we have 100% incisor show one smile without canting. So remember, we are discussing the tools to avoid the unwanted forces in the class C mechanism. Number one was the torque selection. So the torque was very effective in ability. Number two is modified replacement. Where to put the brackets in the class C cases? 5.5 or 6 millimeters. So they should be at 6 millimeters. It's one of my patients, Hadid. Again, she's 46 years old, and she had the same history like Adil. She's traveling again from Saudi Arabia, from the same city, Jeddah, and she had the same history. All of them, they told her that your case is surgical. She has complete profile, and these are the intraoral photos for that patient. The interesting thing is the attrition of the incisor. So again, she was not happy because she told me that I want to go back to all dentists and surgeons and orthodontists who told me that your case is surgical, to fight with them. So this is the way of bonding, and you need to be an artist orthodontist. The first thing to do in such cases is what? Build up all the upper incisors. I'm doing that myself. So I did freehand build up using flower composite. So this is before build up and this is after build up. So this is hair case, before build up and after build up. I spent 1 hour doing the build up for upper incisors and upper canines and lower canines. You need to do that. She was tired, I was tired from the build up, so I asked the team to have 5 minutes break for Hadid. But while she is walking in the practice, I think that she's not the same person. There was a big change in her face just with the build-ups. So I asked the team, please, so this is her vitamin. So she entered the practice with reverse overbit, Once I did the build-up, now she has H2H5. And all the muscles of the face, they are different. And even the color of the skin is different. So I asked the team to take a new lateral staff just after the build-up. Okay? So this is her lateral staff after the build-up. So when you build up, change the profile. Without braces, without anything. And even the soft tissue profile. Even the color of the skin. You see the face now. We supported her cheeks here and here just by doing the build-up. And for her smile, she's not the same person. All of that in 1 hour. So sometimes you need to respect the teeth size. She was so happy. Even the color of her skin, it was anti-aging. So I bonded hair brackets at 6. You will find something interesting. What do you see different in all of my bondage in this case? This is something different. I made it intentionally. What do you see as something strange? You see the brackets in the center? Yes, they are at 6 millimeters, but what I did for the door, I closed the door. Why? Because I want to remember that in that case I bought the brackets at 6. So this is my protocol now. If I bought the brackets at 5.5, I will take the photograph while the door is opening. If I close the door, this means that I bought the bracket at 6. I want that picture to give me all the information needed. I just want to write down. So if you see any bracket in the center is closed, this means that my bracket position was 6 millimeters. One more thing. What do you call these? Black triangle. But we didn't start the treatment yet. So from where we had these black triangles? What's the etiology of these black triangles? Extrusion. Because lower incisors, they have no stop. So they will extrude, and she's 46 years old. So lower incisors, they are extruding with time. That's why you can see the black triangle. So the black triangle was because of the extrusion of lower incisors. So if you put the propine short, what will happen? As we have said, propine short will change the position of the teeth in 3D. So it will do propination and intrusion. So the propine short will help us, in addition to the IPR, to get rid of the black triangle. So remember, artificial controlling, build-ups, and to put the brackets at 6. Let's go back to the 4 tools. The last 2 tools, you need to change the pattern of elastics, and you need to put tabs. The Sabia as example. He is 19 years old, and you can see with me the severe proclamation of upper incisors and deficient mid-face. And imagine if you apply class 3 elastics, what will happen to the smile? You will have upward rotation of the occlusal plane, anticlockwise rotation of the occlusal plane, so you will reduce the incisors show while smiling. So I need to control that. We have almost political spine, bilateral class 3, reverse overjet. It was a skeletal class 3, it was surgical one. What to do for the wisdom teeth? Remember 57? Okay, we need to extract them, so we extract the wisdom teeth. And this is the top selection. If you want to change anything, this should be a little fine tone. So we wanted his case, bilateral class 3 elastics, but Because he has severe class 3, I put the rubber bands from lower force. We put the brackets on the centrals. The brackets on the centrals, they are at 6 millimeters. And because the overjet is too big, I mean the brace overjet, I added my two grammars on the buckle cusp of lower right 7, lingual cusp of lower left 7 because of the first part. Then later on, we reduced the amount of reverse overjet, so I shifted my two grammars to lower 2 centrals. We continue the bilateral class elastics. Now he is in edge-to-edge bite. When I do band removal, for example, I do the revision for the upper right central, upper left lateral, I will mark the door of the bracket with the original torque. So I can remember that I did the revision for this E with that torque. Now we bypass the cross pipe. But again, maybe you like the body, but you need to remember the drawbacks. So we have some sort of lower incisors and we have anticlockwise rotation the whole through the blade. So we need to control now the class C mechanics. So we added 2 tabs instead of the lower canines. I'm applying something, I call it anti-triangular class C elastics. And we are correcting the class C. Now almost we are in class 1. This is the right buckle view. So he has severe class C. So I couldn't apply class C elastics from the canine, but from lower force. At first we put the deep grammars on lower surface. Then later on I can add them on the lower 2 centrals. Imagine this is his part, huh? This is his part. By the way, he's overweight and so big. So I thought that this will give him the chance to lose some weight. But no, still he's overweight. And when he sits on blind chairs, you know blind chairs, they are compact, small, no? Even if you put that chair in the extra position, once he sits, the whole chair will do this. So he is so big. Now we are in the edge-to-edge bar, in the binary position. Later on, I can apply the class C elastic from lower canine. Then I need to control my class C mechanics. So if this is a clock, what will be then the net result of my forces? I mean, this ball chain, this vertical elastic, and I added deep grammar on lower side. So what will happen for the whole dentition? You will have clockwise rotation or anti-clockwise rotation. What will happen? Clockwise rotation. Is this going to support the midface more or less? More. And for that elastic, what do you call it? Is it class 2 or a class 3? Class 3. What's the shape of that elastic? Triangle. And I have 2 patterns, anterior triangle and posterior triangle. So I will call this anterior triangle class 3 elastic. So that pattern of elastics, especially that vertical component, will increase the incisors show while smiling. So you need anterior triangle class 3 elastics in your class 3 cases. At the end of this session, I may have time to share with you the patterns of elastics that I'm using. So I'm using the 4 tools in their case to control his class 3 mechanics. The same for the left buccal view, nothing special. And for the lower arch, we added 10 chambers.
Cái hình dưới á là mình sẽ có cái thông chamber để cho bệnh nhân hạn chế đại hưởng.
While you are doing your plasty mechanics,
Đây là quá trình trong
you are still in the flexible wears. So it's fine to lose some of the tone,
thì ở đây chúng ta sẽ thấy lúc mà cái
especially in lower incisors because they have very thin bone. Then later on, while you are increasing the size of the wire, then you are adding the tabs. You are controlling the lower incisors. We are rectifying the upper incisors, and we are correcting the inclination of lower incisors. So this is the before the treatment with the cross-pipe and the reverse budget, and we are now in the finishing stage. I want to do overcorrection. All of that because I picked neutral torque for upper canines. So the neutral torque of upper canines in the classic cases will force you to finish your case in, let's say, overcorrected occlusion. All of that reflected on his cheeks. So we supported the cheekbone. He is not the best patient. He has a lot of bad habits. He's not cooperative with vitamin D, and he has a lot of carbs in his food. But for the incisor show, this is his incisor show before adding the tabs and anti-triangle elastics. So I want to rotate his smile clockwise. So if you pull his smiling photograph, you see the rotation? We are doing rotation of the whole smile. We are increasing the incisor show for, So by this, you have seen all the 4 tools for the unwanted forces of class 3 cases. What about constricted upper arch? Now this is the area of dental ultima. It has the power to give you the arch development. So we are not going to use conventional brackets or compression and basic certification. Dental ultima will help you, and you remember the new design of dental ultima. All of that will help you to have kicking effect, shoulder to wall effect on your cases. And the most important way is 40 by 35. So tell your patient that they will feel some tension. They need to rinse with cold water, to have some analgesics, and keep that wire minimum for 8 weeks. Don't rush to change the wire. This is one of the most wires. Keep it for 8 weeks, not less. That wire will give you rotation control, 98% of rotation control. This will give you the kicking effect. So all of you remember Kareem, and I told you that we'll cover his case 3 times. So this is the final time. And already his occlusal plane is upward rotated before applying any class 3 elastic. Most of your class 3 cases, they will have downward rotated occlusal plane, which is favorable. So once you apply class 3 elastics, they will have upward rotation. But already he came with upward rotation of the occlusal plane. So I need to correct the occlusal plane against my mechanics. And the maxilla is constricted. He is not in the country. He has to travel from Hungary. And these are the intraoral photos. And by the way, he was referred from orthodontic surgery. So the orthodontic surgeon or the surgeon sent him to me to prepare him for orthodontic surgery. So I told Kareem, just give me 6 months, then I'll send you back to the surgeon to convince him to avoid surgery. And he's so big, he is so tall, as you have seen yesterday. He's big. But he's totally cooperative, he's so kind, so kind. So this is the day of bonding
thì đây là cái ngày
with palatine plastic elastics. I'm going to change any torque. The upper canal they should be neutral torque. We are using palatine plastic elastics. He has only one wisdom tooth on the right side, so I use that wisdom tooth for the debugrammer.
và thế là
But in the binary position, I will send him to the surgeon to extract that tooth and to convince him that no need for surgery.
và sau đó đó là
So this is the day of bonding.
đã
This is the first wire, which is 14. Then I inserted the second wire, which is 18. Then I inserted the third wire, which is 14 by 27.5. Then he traveled back to Hungary. So we had that amount of change. I moved my debugrammer to lower to central. I did the panorama. I sent him to extract 38. And applying now my mechanics to control the rotation of the occlusal plane. And in that severe malocclusion, I'm adding also another 2 tabs between 6 and 7 because the 3 mechanics together will rotate the occlusal plane.
bằng cách đó là để có thể mình
You see that from the buccal view.
đây là mình gọt bên đây nè.
So if you check the mechanics for lower tabs, upper tabs, the classic elastics, the 3 of them, they will rotate the occlusion clockwise to correct the upward rotation of the plane. And we put the brackets at 6 and we have the right torque. The same on the left side, nothing special on the left side. But the special view is the upper occlusal view.
Mà cái hay ấy là mình nhận khi mà mình chụp từ phần nhai cái cục răng hàm trên cái đường của ở đây
You remember,
trên phần
he has severe maxillary contraction. For most of us, you need SARP, surgically assisted expansion in such cases. But remember, 7, 7, 7, they are the best preference for the arch development. This is our third wire. At that time, he has to travel back to Hungary to complete his first semester. So he came back after 3 months. So this is the amount of art development in 3 months. Please, if you have the chance, I need from all you just to hold the wire, which is 14 by 27.5. It's very soft wire. So that wire can help you if you have the right vitamin D level, calcium level, and if you leave that wire for minimum 8 weeks. We left it for 12 weeks, by the way. So the upper 7, they are the best support for your arch development. At that session, we inserted the second Ultima wire. Then now we are in the SASI wires. Now we are in the finishing wires, and with them Ultima, I have these residual spaces, accidental spaces. I didn't have these spaces before. So one of the tips, you can add power chain, relation 2 inch wide, under the wire between tooth number 6 and 7, both sides. For the lower arch, again, nothing special except the debugrammer. We are in the finishing stage now with Kareem, and the same idea to prevent any accidental spacing between 6 and 7. I'm adding power chain under the wire. So from reverse overjet at the beginning, almost more than 3 millimeters. We are talking about 4 millimeters of reverse overjet. Now we are established position overjet. The change in the lateral staff, this lateral staff was taken during the panorama before doing any, let's say, task. So big change in 4 follow-up visits only. So this is Kareem before, and I'm planning to do debonding for him, I think this month or next month. He's about to do the debonding.
rồi đây là phẫu thuật đó.
And
Phẫu thuật về
you remember his size and
mẹ còn nhớ
his height. So do you consider this, I mean the chin, throat distance, do you consider this too much? You remember him, big guy. This is normal. Imagine if you do surgery on the maxilla and the mandible, you will shift him to a child profile. That's why I'm against surgery in males. So the classic cases, my way of thinking is different from males or females. Maybe in females, if this is big malocclusion, just because of the aesthetics, and I want to give females a class 2 profile, maybe I can propose surgery. But for Kareem, of course, we supported the mid-face just by the 4 tools, and we supported the transverse dimension by using our Ultima wires. So we restored the arch width just by wires. And we get rid of the gummy smile because the etiology behind the gummy smile was collapsed upper arch, like the umbrella. So remember this. You have challenges in class C, but at the same time you have benefits. I like class C mechanics because they will enhance the face, and also my feedback, my patients always they have better oxygenation. So class C is not bad. I mean in terms of mechanics if you control it. If you open any textbook, I'll do my best to do that session before the lunchtime. If you open any textbook, what will be the location of Bimax cases? Are they with a class 1 or a class 2 or a class 3 or where? Always they will put the Bimax with the class 1. Where I put the Bimax? After class 3. Because for me, Bimax is a combined. Class 2 in the upper, class 3 in the lower. So if you can treat any severe class 2, and you can treat challenging class 3 cases, of course you can treat Bimax cases without, let's say, extraction, except for the wisdom teeth. And I will delay their treatment because it's not functional treatment. I will delay their treatment to the age of 16 because of facial maturation and because of the age. You know, the soft tissue support in that case, so you need to wait till the age of 16. So if this is your case, this is what I'm doing in Bimax cases. I'm going to use SAD between tooth number 6 and 7 after extracting the aids to apply cluster mechanics in the upper. So that power chain will hold my buccal segment from canine to 7 distant. Then I'm going to apply this pattern of cluster elastic. What do you call that elastic? Is this class 3? Yes. Triangle. But posterior. So we have anterior triangle class 3, and now this is posterior triangle class 3. To visualize the lower buccal segment. At the end you'll have space mesial to upper and lower canines, so you can do retraction. So this is what you are going to do in Bimax cases. What will be the torque selection in such cases? It will be like a class 1 with a crowding. So this will be the torque selection. This will be the torque selection. High torque on the canines, because you are doing class 2 on the upper. So I want my canines buccal displaced. Class 3 in the lower, so I want my lower canines buccal displaced. So they can move. So I got procline torque on the upper and lower canines while I'm applying retrocline torque on the upper and lower incisors. But in some cases, you have compromised relations. Like this case, she has Bimax, pathological drifting, but you don't have enough bone around the upper and lower incisors. So it's contraindicated to put retrocline torque for such case. So she has bone loss. So I put procline torque because of the period problem. But same mechanics, same mechanics. I mean, we'll add 2 tabs distal to upper sixes with posterior triangle class 3 elastics. So same mechanics. 2 tabs between tooth number 6 and 7. I'm doing retraction for the buccal segment. And I'm doing retraction for the lower buccal segment using posterior triangle class 3 elastics. All of that will give you a good amount of retraction, controlled retraction. So this is the profile of the same patient. He has mobile front teeth, bone loss, proclination. This is before the TAS because I put procline torque. So I want to make the apices inside healthy medullary bone. Then I'm going to do controlled retraction, not retroclination. So this will improve the bone around your incisors. And she was happy about the outcome. She told me that I changed her life. And she is the mother of Maya. You remember Maya? Maya, the other patient. They asked me to do debonding for her and her mother at the same day. She traveled all the way from Riyadh. So while I'm doing debonding for Maya, her mother was in the next chair. This is compact eye touch from Land Mecca. She was so happy, by the way. And everybody is asking them, Maya and her mother, why you are traveling from Riyadh to Jordan? Just to change the wire. This is so silly. Okay. But you can see the change in her profile. So we did the bonding for Amanati and Maya at the same session. And we took that spinal for both of them. Okay. So thank you so much for giving me the chance to finish classification.